All right, we will go ahead and get started back then. And I'm going to probably make this shorter, try to make it a little shorter. So right now, who all has required clerkships? Who either has recently or has an upcoming LCME site visit? All right, consider yourselves lucky. So there's frequently this type of reaction to the LCME coming. We've talked about the LCME a lot. Does everyone know what the LCME is? Okay, so it is essentially the accrediting body, and it actually falls under the Department of Education. And so it really is intended to be, it's a self-assessment. There are a lot of things that I think are really great about the process. The idea of like actually being assessed by your peers, this idea of fostering institutional improvement. I would really encourage you to go and look at the standards, because for me, my first year as a clerkship director, I'd gone from having an elective clerkship to having a required clerkship. And oh, by the way, the LCME is coming. And I had no idea what it was. And it was an incredibly rude awakening. Lots of baptism by fire in that moment as to what the expectations were. And I don't know that the institution that I was previously at that point in time really did a great job of educating all of the clerkship directors. And so hopefully those of you who have required clerkships have a seat at the table for your course and clerkship directors meeting and really are sort of involved in that process. But the accreditation standards really cover everything from the building that you're in to the learning environment to how you assess students to what are mental health services offered for them. So it really covers almost everything that you can imagine. But the goal of this is really having strategies for self-improvement. So a lot of these things are going to be opportunities where you can really take a leadership role, where you can think about how emergency medicine can actually play to that. There were things, at least at my prior institution in terms of preparation, there was really an opportunity for emergency medicine to go from an elective rotation to a required rotation, because they're looking for things like when we surveyed our interns post, doing like the intern follow-up of how well do you perform? So things like procedures, students didn't have a lot of confidence going into internship of their ability to do procedures, and other things like caring for sick patients. And so those are really opportunities for us, and the institution as a whole has responsibilities to be able to say, we look at this data, we look at these evaluation metrics, and so knowing that, even if you're not directly involved in a site visit, gives you an opportunity to leverage and to really put emergency medicine in the best possible place for your institution. There are a lot of things that are frequently cited. These are some of the most common ones. Diversity is actually now more recently in this list, and there has been a recent letter that has gone from the Education Committee, where legislatures have actually reached out to the LCME for some questions about how diversity categories are compiled and what they look at. But things related to the learning environment we've already discussed a lot, but things about preparation of residents. So if you have a required clerkship, you are required that all of the residents who participate in teaching, whether they're off service or not, are required to complete residences teachers training. You're actually responsible for making sure that everyone who may come in contact with teaching residents has to know what your clerkship objectives are, making sure that assessment is a big component as well. And so I would encourage you that while people have very different responses to this, but really being able to embrace this as a continuous quality improvement, helps you survive the process, but it's also really, I think, particularly helpful in how do you improve your clerkship and make sure that you're meeting all of the requirements. And so thinking about, these are particular things that you can leverage. We've already talked about the EPAs. Direct observation is a requirement that all students in core clerkships are directly observed. If you look at the graduation questionnaire that gets sent to students from the AAMC, emergency medicine is the only what I think most people would consider non-core requirement. Neurology, I think it probably is even more commonly a core rotation than even emergency medicine. But none of the other clerkships are called out that are not your typical core clerkships. And they actually look at the number of times that you're directly observed. They look at the overall clerkship quality, but thinking about how you can add this if you're moving from an elective to a required rotation, making sure that you have some component, whether that's revolving around EPAs, whether that's actually, and particularly the history and physical is required. These can actually come with other things, though. You could have an OSCE to do this. You could fulfill this by simulation, and making sure that you are linking this to either narrative and formative assessment. There are standards around that as well. Additionally, an opportunity for emergency medicine to get involved in is the required clinical experiences. So the core clerkships are required that the clerkship years, you have to actually designate what are the required clinical experiences that you expect your students to see, as well as these other types of information, the types of patients, the clinical setting, the expected level of responsibility. This is really an opportunity for emergency medicine because we see all of these types of patients, and to figure out how it works for your institution, whether you're assigned some of these to be seen or whether they could be makeup sort of opportunities for students, or some schools actually disperse this and students can fulfill these in any rotations. So it really depends on what what the expectations are. And then these have to be tracked over time. They have to actually be monitored at the clerkship level. And so you have to be able to say with confidence that we can ensure that all of our students actually see all of these types of patients, and then it has to be tracked at the school level. This is one that no one really told me about when I was a clerkship director, that all grades have to be turned in by 6 weeks. So hopefully your institutions, this has become a really hot topic with LCME. This is not something that they tolerate one day over 6 weeks, and you really have to be able to designate this. They really have the expectation, I think, that all clerkships, whether they are electives, that all grades are turned in within 6 weeks. I think for the most part, they have really focused on things that are like required core clerkships, but keep that in mind as well. Formative assessment and feedback. I will say overall, the LCME has actually taken has placed much more emphasis on student opinion in recent years. So they've actually taken out many of the graduation that fall in the graduation questionnaire and remove those with what's called the independent student analysis, which is an incredibly poorly written survey, that it's a little embarrassing that it's actually drafted by a group of educators and put out there as the national standard. But they have put increasingly more emphasis on this, and I would encourage you that if your institutions are not incorporating that as part of end-of-year surveys, that as they have placed more emphasis, it will maybe prevent some more heartache along the way if you're looking at these numbers on an ongoing basis, as opposed to waiting to the year and a half or so before the LCME comes, and then you get incredibly surprising data that can be very hard to address in the meantime. But formative feedback and assessment is one that has been very near and dear to our students' hearts. I think thinking about how you provide this, the expectation really of formal midterm feedback for the students. And the goal of this is so that the students have an opportunity to be able to change behaviors before the end of the clerkship. So it should not surprise the student that they're going to get a certain grade at a certain time. And it doesn't mean that you have to tell them the grade, but if you are consistently, if you know that the student is having trouble putting together a differential diagnosis, they really deserve to know that in the first part of your clerkship, so that they're able to focus on that, work on that, and try to improve that over time, as opposed to sort of feeling like they're hearing about it for the first time at the end. And so really thinking about how do you formalize this process. I would argue that actually writing it down matters. We actually incorporated students actually having to do a self-assessment so that they participated as part of this process. Because I think for the most part, the students actually know what they're doing well and what they need to improve upon. And that really helps engage them then in figuring out what should they be working on for the remainder of the rotation and how do they navigate that. And again, I think students don't want to be blindsided at the end when that comes time for their grade. They don't want to feel like they're caught off guard and surprised by feedback that they've never heard until the end. Additionally, making sure, shift cards do fall into this, the ongoing feedback as well. And so you frequently tell students that, to me, it's a continuum from formative to summative, that every shift that you work is some component of it, but it all rolls up into what that summative assessment is. But making sure that the students get narrative feedback as well, and high quality narrative feedback, which will be covered later, but making sure that we're adding comments other than read more and those sort of worthless statements that sometimes people tend to incorporate. Curriculum management, again, this ties into curriculum mapping and looking at the content that's taught over time. So the clerkships are not the owners of the content, but it really is about the medical school has a responsibility to see where all of this information is integrated. And so this is a great opportunity because emergency medicine is so broad. Lots of times what happens is people identify that there's a gap, that we either haven't taught it appropriately or we need better opportunities to assess students over in this larger scheme as we're looking at the entirety of their medical student experience. And those things have to, then they can find gaps, and then it's really the curriculum counsel's responsibility to make sure that those things are covered. But that's also a great opportunity for emergency medicine to be like, hey, we can cover this in our clerkship, and it really helps bring value, I think, to the emergency medicine rotation and to find you have a greater influence within the curriculum. But making sure that you realize that everything that would be like a change in your clerkship objectives, all of those have to go through that central curriculum council or curriculum committee for approval. And that's one of those expectations as well. Again, anything that you review or revise your curriculum, especially for required rotations, because while in reality, it doesn't always work this way. This is really supposed to be part of a greater whole. And so anything that you change could also impact what isn't, that the medical students may not be getting the content that they need. And so we're really looking to making sure that we have integration of content from clerkship to clerkship, both in the preclinical phase to the clinical phase. And so being able to step up, making sure that you're doing all of these processes is really incredibly helpful, and I cannot tell you how valuable it is. And then as you're going through an LCME accreditation visit, the other thing that I would mention is I cannot tell you how helpful it is to have those key players who are actually advocates of change, doing something new, recognizing that there needs to be quality improvement. And I think that's something that emergency medicine physicians in general really excel at. And those really, this becomes an opportunity for you to figure out how to continue to grow your career over time. Making sure that you are tying into every institution has institutional or education program objectives, and making sure that what you're doing ties into those and supports those learning objectives, and making sure that everything that you're doing, that you're assessing in some type of way, and that you're linking your objectives or your competencies to the assessments is all information that feeds into your curriculum mapping tool. Thinking about how you are connecting apples to apples, and we're going to go into this a little bit more in the next session for assessment, is really important as well. And making sure that students are, especially if you have multiple sites, you have to have site comparability. And they're going to ask you, how do you know that your students perform the same? And so looking at outcomes related to whether that's looking at required clinical experiences for the students, or looking at, did the students score the same on the test? Or do students who rotate at hospital A have lower scores than they do at hospital B? And those are expectations that as the clerkship director that you're looking at that data and those metrics and really making sure that while your students won't have the same experience, that they'll have comparable experiences and should be able to expect comparable outcomes related to that. healthcare providers cannot assess students. And so this typically is really around mental health where we think about this the most. But thinking about that, at one point in time, I had a student with underlying mental health condition who had a psychotic break while interviewing a psych patient in the emergency department. And so it really opened up a whole can of worms because the one of our faculty actually had to intervene and provide care for the student. And so really thinking, for the most part, most of us probably don't actually remember if we saw the student who was an M1 and playing basketball and sprained their ankle and ended up in the ED. Probably none of us, whether it's the student or us, remember exactly who that was. But for anything that is a sensitive subject, you really have to think there can be no role in assessment or promotion of the student. So had a student who ended up in the emergency department intoxicated one night. And so then as the clerkship director, if you're aware of that situation and there's an issue that goes before your promotion and advancement committee, you cannot share knowledge of that and you should not participate in those decisions if you have anything that would represent a conflict of interest. And then just make sure that there's really an opportunity for us to think about teamwork. Teamwork is a whole separate section of the DCI, and you have to write about how you train and assess students in this. And so we really have a unique environment that really would allow itself to think about 360-degree evaluations and assessments for our students. So these are things every year. If you are a clerkship director and you have other hospitals that you're sending students to that are outside of your network, you have to make sure that you have affiliation agreements. All of your community faculty have to have affiliate faculty appointments if they're not part of your main institution, and you have to document those things as well. And really think about what are the opportunities for you to be able to excel and bring value to your institution, to your Office of Medical Education, because these are really things that create, being able to help solve some of these challenges are things that create roles for you in the next phase of your career as you're looking for other opportunities. Any questions at all related to the whirlwind coverage of LCME? All right. Where do you want me to start on, Jules? Where?
That should be just wait for
Did the slides actually, they showed up at the time, right? I was like, I was hoping you would stop me.
No, we just watched you, kind of, saw laughed at you. So yeah, so I assume Jules is stuck in her SAEM meeting, so we're just going to kind of.
All right. So I will try to do this on the whirlwind and not having looked at Jules' slide, but having done a lot of talks with Jules in the past hopefully serves me well. And so I would say the caveat of this is I've worked with Jules closely in sort of the NCAT development. But so why do we assess students? This is really the crux of what we talk about. You know, I think we are in an era where we are struggling with grades. What does grading mean? There have been a lot of unintended consequences, in my opinion, of step one going past fail that we didn't really think about. And I think I personally worry a lot about the validity of grading and the potential for bias to be incorporated into that. And I think if you've read any of the literature out there, I think we all have some degree of bias in our grading systems, whether that's from personality, how well you get along with an individual students, as well as some of the other items that we discussed along gender, race, ethnicity, and things that really sort of give me indigestion along the way as to how do we make sure that we have an assessment system that really provides our learners with what they need to grow and develop. And so we do this to provide professional growth, to drive learning, to making sure that our students are competent. I think this is a big one for me. We have an obligation to the public to ensure that when we graduate students, that those students are safe, to be able to take care of patients, and to be able to to make sure that they're able to provide adequate care. And then, as we've discussed with SLOE and other things, we have to provide grades and rankings in ways that can be really difficult. And I think sometimes these are odds with one another because we talk about time-based versus competency-based. And if we are really just caring about competency, we wouldn't have to rank them, but then we're on that other edge of having to hand off to residency program directors and knowing that they need some metric by which they need to select residents that are a good fit for their programs and who they think will be successful. And so when we think about this in terms of this is measuring their competency. And so everybody, I'm sure, already knows this, but formative is the feedback, and then summative are things that are evaluative, and that really gives a sort of value ranking, whether it's scores, grades. To me, most of this is on a spectrum that ideally most of these things would feed up. There are some things that are completely formative, but things that are lower stakes typically feed into some of those summative competence. And when we talk in the purest sort of terms, we talk about evaluation of curricula, we're really talking about programmatic assessment and how do we actually evaluate the curriculum. And so we need to make sure that our learners have the knowledge, skills, and attitudes. And we have to be able to objectively define what these things are, and we have to make sure that they're measurable outcomes. So every time when you're listing like your clerkship objectives and you're talking about the learner should be able to, perform a history and physical, as an example, you have to be able to say, how are you assessing that? How do you know they're competent? To be able to really describe to the learners what are the expectations related to that. And so there's a lot of confusion. There's a lot of different lingo from UME to GME and how these things fit together. But when we think about competency domains, those are those big buckets. Whereas when we think about milestones, we think about what should that expectation be over time and how do they learn and grow. And then an EPA is really just one observable unit of activity. So it's on that one day at that one point in time, and it actually can involve multiple competency domains that you have to be able to do. Like if you're getting a history and physical, you have to actually be able to communicate. You have to be able to physically do get the history and then be able to perform the physical exam. But it also involves that you're professional and all with it. So all of these things feed in there together. And so when we talk about assessment, what we really want to make sure is that what we want is a valid and reliable instrument. So reliability speaks to the fact of it's precise. So it can be precise, it can be reproducible over time, and it can be completely off the mark of what we're trying to actually accomplish. Whereas validity really determines that we are accurately measuring the construct that we're trying to measure over time. So if we are trying to measure the fact that a student is able to be professional, we might be able to get some reliability by asking some multiple choice questions on it, but we really want, if we're really talking about seeing them be able to demonstrate that in a clinical space, then you're going to have to measure that in a clinical space, which sometimes can make it hard to get over time. And so looking for both validity and reliability. So again, these are the validity is on a continuum. It's really hard. Reliability, I think, is sometimes easier to get, but it doesn't necessarily mean that you're measuring the right metric of things. But again, having a valid instrument, but that's not reliable, then that doesn't allow for student-to-student comparisons in any type of way that is fair to the students. And so some of the common things that we look at to be able to assess students, we talk about their shift cards. We do direct observations. There's frequently a medical knowledge test. You can do simulations or OSCEs, computer-based simulation cases where does anybody use those within their clerkships at all? where there's like branching logic, and it will have, so there's cases where you can actually have students say, these are the tests I would do next, this is the step I would order next, and even things that can time you to see how quickly you get to the right steps. And then documentation review. And all of these things have differences in what's more likely to be reliable versus valid. And you'll notice that national exams really have the highest reliability and validity. I mean, they pay tons of psychometricians to make sure that this information is correct. And yet, I think when we step back and think about what are the competency domains that we're trying to measure, it really is the best measure of medical knowledge, but not many of the other constructs that we're attempting to look at. And so I'm going to leave that this is Jules feeling some sort of way about assessment here. This has been a lot of sort of ongoing topic of debate within the clerkship directors. And we really want to make sure that we're hitting the mark with these. And so when we talk about things related to the shift card, these are things that we all use. Does anybody not use a shift card? And when I say that, like the daily type of, you're working with somebody and you're having them mark off. And so typically we are looking at things related to skills as well as duty. Is somebody engaged? Are they professional? What you find from the literature sometimes, though, is when you get to that overall score and you're asked to give a global score, that overall score actually predicts and influences how they will, how a rater will score them for each individual domain. This is when, you have the tendency to mark either all down the all, like I've given this person all 5s versus all 3s. And so really your overall gestalt of that learner is very, it has a tendency to really sort of make you sort of pick a category as opposed to really thinking through, how did the student do on this particular competency versus were their procedural skills different? And it requires a significant amount of rater training to work as intended, and there's huge potential for bias. You work with the introverted student, and sometimes you're like, did they not know, or did they not speak up? And you draw all sorts of conclusions on your own that may or may not actually be an accurate representation of the student's ability. And so you keep those things in mind. So most of the time, these are anchored format. Sometimes they are that they're mandated across all of the clerkships that use the same form. Is anyone in that situation where all of your clerkships use the same form? All right. So those are lucky because sometimes those are very challenging. But we all tend to use different things, and this makes it very hard for us to all use incredibly different metrics and then bring that together. And so as a disclaimer on this is some of the work that both Jules, myself, many people in the room have contributed to and really worked on developing the NCAT, was trying to have a consensus tool that fed into, that would ultimately be able to feed into the SLOE and use some of the domains. The institution that I'm currently at uses an ORIME model, which is the observer, reporter, interpreter, I'm totally blocking now on what M is. Manager, thank you, and educator. And I actually find it a little more difficult to anchor what my expectations are on that as opposed to very specific behaviors, but there are a number of different tools that you can use. But again, frequently influenced by your institution. And so if you have to develop your own tool, what I would encourage you to do is think about how many domains and levels of expertise that you want to incorporate. I do personally struggle with entrustability skills as a disclaimer for that because we're not frequently entrusting much of anything to anybody without some degree of supervision related to that, and so I struggle with that. But making sure that you have clear expectations because it is incredibly difficult to train faculty to make sure that you are rating that these behaviors constitute an average performance, these behaviors constitute an honors performance, and you want to make sure that you have behaviors that can really create a shared mental model amongst your faculty members. And when they don't, really think about what do you think about and how do you actually train those faculty so that they have the same shared mental model? Because I think that is one of the most frustrating things from the student's perspective is they have this person, if I work with this person, I'm going to get honors, but if I have too many shifts with this person, I'm more likely to get a pass or maybe a high pass because even when I do the same exact behaviors. And so some institutions do use a Z-score where they norm, it helps norm your hawks and your doves. But the challenge there is, I think as a student, it's really hard to get a bunch of forms that say, you're the best thing since sliced bread, and then for me as the clerkship director to say, yeah, but that's actually only a pass because you got a hard rater. And so to me, it's really, while it's actually probably harder to change behaviors over time by influencing your faculty, I think overall that's, in terms of what's perceived as fairness to the students, that's really is probably what the students, if I were a student, I would perceive as most fair, is that we put our effort into trying to better educate our faculty and get improved inter-rater reliability amongst our faculty members. And then sort of be able to provide descriptors that really give some of the nuances, really think about some of the learners who might be sitting in different areas and give examples that are clear. So on the NCAT score on this, we actually, as part of the consensus conference, we decided that we could not figure out how to determine professionalism, like what is timeliness of like people being punctual and timely and turning things in on time, and like how is that sort of exceptional versus sort of what the expectations were. And so those things actually the group, and it was a group of over 100 people, determined that those should be binary. You either do it or you don't. There's not really a lot of in-between in some of those behaviors. And so, so that's why some things actually are best actually laid out if they're binary. And so, again, we've already discussed a little bit about this, but I think our students really are incredibly frustrated by us when they don't know what the expectations are. So we need to be able to transmit this information to our learners so that they know what their goals are for the clerkship, but also for our raters to know what the expectations are. And so as the clerkship director, this is really an opportunity for you to provide feedback to your raters as to how they're doing. They can't put information in an evaluation that says that that this person is a 5, but then give all of these things that they need to be able to improve. And so, again, this is one of these sort of things that's really important to me. We need to be able to provide formative feedback that's low stakes on the shifts, with you being able to reassure faculty, if this is the only time that I hear that somebody left their stethoscope in the car and is 5 minutes late, it's never going to show up on a summative assessment of the student. It's not going, or on their formalized, final grade form. But if you find out that the student was 5 minutes late here, and then they disappeared for lunch for an hour and a half on this day, and then I asked them to go get a Doppler for a pulse check for somebody else, and they went and got a snack from the cafeteria, those things are all add up over time, and then those actually become very important. And then the other piece of this is really thinking about how do you work with the person at your institution to really think about how do you monitor for bias within your clerkship? How do you make sure that you aren't introducing, that your faculty don't have bias that's inadvertently putting some group of learners at, that they don't have the same equity opportunities that your other learners have. And again, the pitfalls, we know that we have fears. We've already talked about this some today in terms of the SLOEs. We don't want to harm the students by calling out the behaviors. And so that's really an opportunity for you as the clerkship director, again, to give that reassurance that One single episode of truth-telling to a student is not in and of itself going to ruin the student's career. I think we institutionally have a lot of work around to do about this. People then have a tendency, it's this halos or horns effect, that you know of them from some other thing, or that you've heard that they're great to work with, and really keeping these things in mind. What we do know is that white students are 2 to 6 times more likely to receive honors grades than students of color. There's tons of literature in the past several years about this. We've already talked about the race and gender stereotyping and narrative assessments. And these are things behaviors that have gone on over years. These are things that are frequently implicit bias or unconscious bias. We need to really think too, as clerkship leaders, as to how we work to change that culture within our institution, to make people more aware so that they're not writing those things in the narrative comments, and to really provide them with a skill set that they need. And this really, why does this matter? Because there's an amplification effect. So I can tell you that we already know that there's things within standardized tests that create concerns around bias and that put groups of students. But then when it's compounded, and those things and the individual evaluations feed into grades and then SLOEs and MSPEs, and down the road, they actually have pretty significant implications for students' careers as a whole. The challenge is how do you combat this? And we are doing a lot of work at my institution currently around this. And the answers are not easy with how to combat this, I think, because so much of this is unconscious. And so training is not as effective as it should be in the literature. I think it matters a lot to students, though, because it matters that you've tried. And so making sure that your faculty get annual training on that they're aware of these things, that we're really focusing on actions and observations and not our personal feelings about students. And then really stepping back and saying, before you submit the final, is this balanced? We want to be truthful, but we also want to make sure that it's constructive feedback as well. Multiple choice exams, these are we already discussed that they're the most valid and reliable, but they frequently don't measure the constructs they're not all encompassing. And so while there are questions about ethics and professionalism in there, I know, Joe, you write for them as well. I'm on the committee. There are things, I cannot tell you the number of times that you write a professionalism question and you write the stuff that happens in real life, right? The nurse will report you to the, whatever. And the MBME writes back, is this even a plausible answer? And yes, some of those things are things that happen in real life. But the MBME is an option. There's a cost associated with that for the department. The SAEM test exam is free and it's available, but I started out writing my own test and it was a disaster. So I would highly suggest avoiding that. You can do simulation-based exams as well, and this does, if everyone's heard about the Miller's Pyramid, we really want to get up so that students aren't just knowing how to do things, but really demonstrating their ability to do the things. There's lots of pros to this. The cons are that it's incredibly resource and time intensive, and to really establish validity and reliability, you have to test these cases with large groups of students. Same thing as well for OSCE exams too. You can assess students through their writing and presentations, and so this gives some more opportunities to be able to get insight into their ability to research things, to select topics of interest or focus for them, to be able, again, the challenge of these is to be able to grade these, and grade these consistently requires that you develop a rubric in advance for these, that you train all of your faculty who are assisting you in grading these to make sure that you have a consistent expectations and a shared mental model around that, and that you're looking at data. I cannot emphasize enough that none of these things happen without having a data-driven approach to that, and so working with your institution to make sure that that you have someone who can help you assimilate that data, because for most of us, that is not a skill that we have to be able, or time or the resources that we have. And so limiting a small cohort of people who grade and making sure that they're well-trained is incredibly helpful. And then how do we kind of pull this all together? So there's been a number of more schools going to pass-fail in the clerkship years. There's pros and cons to that. It does help reduce some of the bias concerns and equity concerns that you have, but I think, then there's the other side of that, and in a time where there's no step scores and step 2 scores maybe later, how do we actually differentiate what learners that we would like to have join us in our residency programs? And so, and again, while it deals with the equity issues on one side, I think, again, students want to be able to show how they're different and set themselves apart. And so there's those options we talked about. Normative, where we're really looking at sort of where people fall, versus criterion referenced, where we're saying that that here's the criteria, and once you achieve that criteria, you're good to go, and we're sort of putting our stamp of approval on you. Compensatory versus non-compensatory. These are things where you have to be able to achieve like success in all of the metrics, but then really setting aside what you, and then how that fits into the grade. And then we've already discussed sort of the red flags. I think probably most of us have a lot of experience with the normative versus criteria-based, that we really are looking at how learners, as we talk about competency and that our learners should meet a standard, but we're really sort of also being held to the old school metric of how well are they performing and where will they go on the rank list. And I do think the newer version of the SLOE helps us get a little closer to the behaviors and looking at some of the competencies as opposed to top third, middle third, bottom third types of the questions in the older version. Compensatory is probably what initially used, and this is the percentages of how that figures out from your clerkship evaluation, and it's a certain percentage. Non-compensatory, really, so this is actually what we use for our OROM model. Like, students have to get so many evaluations of exemplary versus get outstanding on their professionalism, and it allows you to set different threshold criteria, but that all feed into it, but it's not just a numeric score that you get a grade on. And so those are, sometimes it's felt that the non-compensatory factors actually help, gives a little bit more room to account for bias, and it gives students with different strengths multiple opportunities to be able to achieve honors, as opposed to just sort of a numeric score, of which frequently the shelf exam is what determines the grade when you're using the compensatory mechanism. And so I am not going to go into great detail for this, but there are several standard setting processes that you can do to set your standards. Hopsky and Angolf are both things that the MBME use. The challenge with that, though, is if you've ever looked at your MBME criteria, there's 2 different sets of scores, and you have to determine which one that you're going to use. And so this is something that I would say is beyond the scope for most clerkship directors, and really requires engagement from a psychometrician. There are some cases here. I think we will just stop at that point and see if are there any questions related to assessments?
Or even about anything we talked about today. To kind of have this like last 5 minutes or so, just kind of slide around for questions. Yeah.
I recently, for the students who are on the side, like, get a photo from me, I sort of made an assessment from the SLOE.
Well, I would look at the NCAT if you haven't looked at it before, because again, especially with the revised SLOE, a lot of that was pulled from that. And the nice thing about the NCAT is, I mean, there is a lot, if someone were to question you about it, you can pull up the paper and the process it went through for doing that. And there's even been a couple of papers that they put out afterwards, looking at the data and its validity and evidence and stuff like that. I think it's always tough with the kind of the homegrown ones is, someone, potentially could pull that out and say, well, again, like, how do you know that this is valid? How do you know it's, that sort of thing. I don't know if you want to speak more on that from your side.
I think this is a huge challenge because there's a huge disconnect, I think, for us as to what we need to measure because what we're teaching in the clerkships really has more to do with what are our learning objectives, and it's all related to institutional sort of educational program objectives. And then there's pieces of this that are more based on the SLOE, which are about residency. And so there's some of those things that I think work great for both, right? Communication skills, professionalism, teamwork, some of those things could be particularly helpful. But then there's some of the other things that maybe aren't quite as clear. I mean, and the one that comes to mind, the old version of the SLOE was like dedication to EPA. And it just doesn't fit in anyone's pocket. And so you're not getting the information that you need. And so to me, this is a huge disconnect between it really goes to what are the purposes of the tools in which we're using. And so, figuring out how to feed those things in. The other thing that I think you can do is some things we measure differently and other things. So like procedures, we're frequently not measuring things like everyday sort of things. So maybe you need actually a separate evaluation tool for some of these other competencies that are a little more removed or separate. So I think you have to think about both the big picture, what's the goal of assessment in your clerkship, and the residency application process is necessary, but also a little separate. So making sure that there is as much alignment between those as possible, I think is something that is our responsibility sort of in the sort of clerkship residency space to make sure that they're together.
Yeah, so that is what you had said is creating specific assessment tools for various parts of the SLOE is like kind of what we're doing. So like we've moved away completely from any didactics. It's all like modules, and all of our in-person time is just assessment. So like for procedures, for instance, like we do a direct observation of them putting in an IV, doing single interrupted sutures, placing nasal cannula and a nasal trumpet, and putting on a pelvic binder, like all these general procedures. And it's very similar for some of the, like for history and physical, we do a direct observation assessment. So we have taken what students do, our end of shift evaluation or assessment tool is nearly identical to this one, but it really focuses on the tasks that they complete during the shift, and everything else that the SLOE might have, we create separate assessments for. And what I think is actually really interesting is what we, for all EM-bound students, we actually, by the end of the year, they go through Bootcamp, and some of them do all results exams, and we'll actually create, we'll do a milestone sheet for them and send them to the residency, like where we think they are on the milestone, so the EM residency milestone.
All right, otherwise, thank you, everybody. You should have access to these slides, besides for a couple like last-minute updates already on the app. If not, feel free to reach out to any of us, and again, our contact information should be on there. You can send them out as well. Thank you.